Next session features Lacey Wind, who is the Vice President of Tribal Public Health Programs at the National Indian Health Board, leading national strategies that strengthen Indigenous health systems and advance tribal workforce development for all 574 federally recognized tribes. With more than 20 years of executive and clinical experience, she focuses on building sustainable tribal health infrastructure, expanding workforce pipelines, and advancing culturally centered policy. A licensed clinical social worker, Lacey has led integrated behavioral health and medications for opioid use disorder programs, developed workforce pathways for community-based paraprofessionals to licensed providers, and mentored the next generation of social workers as a field supervisor. As the founder of a tribal nonprofit, she directed culturally grounded health initiatives designed to grow local capacity and long-term sustainability. Lacey is passionate about strengthening the tribal health workforce, mentoring emerging leaders, and advancing solutions that empower Native communities. She is also a proud wife, mother, auntie, daughter, and sister, deeply rooted in family and community. So please take it away, Lacey. Thank you.
Happy afternoon, everyone. Apparently they saved the best for last. I'm just teasing. Um, like uh, like you all said, I am Lacey Wind. I'm the Vice President of Tribal Health Programs at the National Indian Health Board. I'm a Northern Cheyenne citizen, originally from Southern Montana, but I am located temporarily in DC at the Office of National Indian Health Board. Um, I was tasked to really talk about workforce strategies and best practices, policy recommendations, and I do want to talk a little bit about some wins that we've had kind of in this dark times. It's always exciting to know. Sometimes we always talk about the struggles, but we have had some wins that I will pull up and talk about, and then I was asked to really talk about understanding the current political and funding landscape, so how all of this kind of affects us. Next slide. So, if if nobody knows what NIHB does and who we serve all 575 recognized tribes. We are tasked by the tribes to really be a united voice for all 575, which is a big task. We do our best, but it is a big task to go forward with. Uh, so under the scope, we have a policy side, and then we have a programmatic side. So I am the vice president of the programmatic side. My side is really working with all the tribal health organizations to help them build capacity. But we also, in tandem, do policy advocacy trainings. And really at NIHB, we are the conveners to make sure that we create a united voice. And we do all this and we focus on tribal health systems while honoring our sovereignty. Next slide. So we have several roles. Um, we are really that national voice. We are governed by a board. So the 12 tribal or there's 12 IHS regions, and they have one representative from each region from a tribal health leader. That is our board and our makeup. And then our tribal organizations are our area Indian health boards. Um, we make sure that tribal leaders' voice is also impacted into federal policy. Um, Next slide. So let's talk a little bit about, and you guys kind of all stole my thunder in your last conversation. So we're going to say kind of similar things, but I think that's the purpose of why we're here today, right? Is to really talk about what we are doing at NIHB, kind of talk about what you guys were discussing really as policy level and kind of doing this mind melt. Uh, So really thinking about how we're strengthening AI and healthcare education, um, is that we all know that tribal-led program design and decision making needs to be the voices of tribes and the tribal community. That needs to be the foundational point. We need to really always advocate. I think that we're starting to get there, but really always advocating for culturally grounded education models, and really honoring those models. Uh, we definitely all support, that's why we're here, is that we support your all efforts at iHeart for that early pipeline development, K to 12 to career, and really investing into our children early. I think making sure that they know that they have a place in healthcare, making sure that they know that they are the experts in their care. We are all in support of that with iHeart. We also have been thinking through, have been developing partnerships, and been really advocating for partnerships with tribal colleges and universities and community, but not really like when we say partnerships, I think and then you say like tribal colleges, and then you say universities, and then you say communities. Those all still feel compartmentalized. What we are really advocating for is really having a pathway, a spectrum, so that at any door at any time, you don't really have that linear pathway to education, but it's really you can access it and partner in many different ways, from community all the way to university and back to community. Also, uh, we're big fans, and because we know that it works, of really growing your own workforce strategy. And we'll talk a lot about that more actually in several slides because it's my big thing. And I was like, oh, I had that in like slide 3. So, but we know that it works in our tribal communities. We know that growing our own works. And so thinking about growing our own, really thinking about that paraprofessional model and starting with, CHWs, doulas, midwives, peer support specialists, things that can happen when we're thinking about really being flexible in a non-linear pathway. So thinking about how that can happen, at many different levels at different ages, right? So how can we be a part of our healthcare in different ways versus kind of that Western linear pathway, that everybody thinks is the only way. We know that the CHAPS model works and that expansion of CHAPS works. We know that integrated behavioral health approaches and integrated behavioral health and primary care works. We know that I really feel that that's a really tribal thought model, right? Because we all know that you can't put a head in one building and a heart in another building, and then they're not supposed to talk, which is a really weird system. But really, in that integrated behavioral health and primary care, we're focusing on that whole person where you can access a lot of services as a one-time shop. Also, really thinking, and we talked about this, or you guys talked about this before we jumped on, about really advocating and making sure that we have paid internships and fellowships. Not only is it helping with that part of, the other pieces that involve education, just making sure that we're decreasing those barriers, but it also gives students know that they're valued. We have a lot of educated professionals still that provide expertise and opinions, and they feel like that, right? Because culturally, that's what you're supposed to do. But we have kind of this thought that we shouldn't be paid for those things. And we should. You should be paid for your time and your expertise. And so we really need to try to go forward in that way of thinking and making sure that we're having paying those internships and fellowships. and making sure everybody knows their worth. Next slide. Sorry, I've tried to have control issues and tried to switch it. Also, I like to talk about this. I think we probably all here understand this and are total agreement. But I think we have to continue to advocate to make sure that we are incorporating culture of humility and safety for our students. So not kind of back in my day where we kind of checked the box and did like culture competency where they said, oh, you don't like Indians don't smile, which was always funny when I read that because I was like, oh crap, I didn't know I wasn't supposed to smile. I thought it was pretty funny. But we really need to understand cultural humility within our students, within our workforce, and within our systems. And then also making sure that, it's just not that checkbox that we're having that ongoing practice of reflection and accountability. Are we really doing this? Is this really providing safety and cultural humility? Um, and then creating safe learning environments for our Native students. Next slide. I think some of you talked about this previously, um, but really thinking about our tribal health organizations and having some tribal training sites. So having rotations and residencies and fellowships within those sites. Because they are unique sites, they have their own way of doing things. The community, the tribes look different. And it's really that real world learning and grounding in community. So I would love if we continued to advocate this and figured out how to really make these tribal communities and tribal health organizations um, a training site. I think Dr. Owen already talked about this, but exactly what I was going to say is that, like we think about making somebody healthy, we know that it's just not the Western think of health. It is also the social determinants of health makes somebody healthy. And we have to then incorporate those things similar to our education for our children. So housing, childcare, transportation, um, broadband access, especially if we're thinking about having to do like 2+2 models within our tribal colleges or um, doing kind of more training services for our paraprofessionals, making sure that we have thought through broadband services within community because that is a huge access issue. Also, having cultural responsive student services, I think that this in general, as we get more students in the workforce, more students kind of more in professional areas to treat us as natives and having natives have natives treating us, I think that we would have more cultural responsive services. So having a therapist that is native, so you're not having to, talk all about your culture and then you never to actually get to the issue, right? Like that is a big piece for our native students and for our population in general that there we go that we have providers that understand where we're coming from, um, including when we are in education. Next. You guys also talked about this, so mentorship and pathways. Uh, Really having Indigenous-led mentorships models. I think we have to be doing this all at the same time. So thinking in tandem, having to create these kind of pathways and these workforce pathways that are not necessarily linear, but also thinking about mentorship pathways. But also not necessarily thinking in Western model that that has to be a professor, right? Thinking about how we have lived experience and how we can utilize our elders and our aunties and really creating that relational accountability in our education. Because if you have somebody that you feel is an auntie and they're going to get on you, you're probably going to do it, right? So relational, we are grounded in relation. And so our mentorships are really, I think, are really going to be important in creating kind of this holistic, supportive workforce. Okay, next slide. So thinking about workforce realities in tribal communities. Next slide. So I'm going to go over a little bit of our fixed survey. So we have a public health Indian country capacity scan. It's one of its kind. There isn't a lot of data just for tribal health organizations. So this is the only one that is available. We are in the process of doing a new edition this year, and we work with CDC. Um, but I think that this is really going to be important, and we haven't had a lot of participation, and so really doing this new edition, getting a lot more participation, getting really good survey questions is really important. But we do have some good graphs that I will show you that I don't think anybody will be shocked by. But when we talk about tribal organizations, right, really that could look many different ways. It's really integrating that public health and direct service together. And depending on your tribe, um, it would look different and you would have a different, some have clinics, some have hospitals, some like my tribe has behavioral health and substance use and some public health capacity. So tribal health organizations can look very different. So when we're talking about that in the fixed survey, know that they have a different kind of menu of services. Next slide. You can skip the next slide too. Yeah, go ahead and slip. Oh, you can't see this very well. Sad. Okay. So this is one of our graphs, but you can really see, so the green is really about if I was at full capacity for a tribal health organization, what percentage am I at? And so 63%, actually, if you can see, most of this is like 50% or above, which is crazy, right? Like to be at full capacity in these areas, um, they need to have 59% of their workforce filled, which is, I mean, I don't think it's surprising, but it's crazy to look at it um, in a graph. So next slide. My old slides didn't have the 14, 15% because that was more detailed. But if you add all of those pieces up and really about full capacity, about 2,306 additional healthcare positions are needed to operate at full capacity for tribal health organizations, which is pretty mind-blowing. So 67% report difficulty finding skilled staff. So that's not even indigenous skilled staff, right? That's just skilled staff in general. So at one point we would like that to be indigenous, like a higher percentage of actual indigenous skilled staff. Staff opt off, we know this in our communities that staff often serve in multiple roles. And then workforce shortage causes delay and delay in access. So 40% wait weeks or longer for workforce support. Uh, I'll tell you, I was going to tell you later, but I'll tell you now. We went and visited my tribe at the IHS, and they had some people that had been, they had the already hired already in community. So we had people just waiting in community to work at IHS for over a year. And they were waiting on the background check. And there was multiple people. Um, so timing matters, right? Like this isn't just a workforce delay and we're going to like postpone our taxes. Not that great example, but it's really not an accounting matter of postponing our taxes. This is really life or death. So when we have these workforce delays, it's really a matter of life or death, and really outcomes and really shows those disparities that we have within our tribal communities. Also, if you're wearing many hats, um, you already don't have a lot of people, you feel like your job isn't sustainable, it really causes that stress of burnout, and then workforce strains the whole tribal system, especially at this level that we have. Next slide. So policies, funding, and workforce, we can kind of talk about, next slide, um, what things at NIHB we are focusing on, and what we are watching. I think we're always watching federal policy, budget, and appropriations for tribal health. Sadly, we are always watching Indian Health Service, workforce shortages. Kind of the new thing that we can talk a little bit about is the IHS realignment and structure changes and what that looks like. And then we're also always going to have our eyes on Medicaid and rural health policy changes. Next slide. So, what are some things that these things are all kind of shaping the workforce? I think that the realignment and the thought of realignment and how we're going to advocate for that will be really interesting. Um, and then also kind of how IHS is saying out loud some of the issues, but if we really think about the alignment, the issues seem to be bigger, right? Like they don't see um, tangible solutions. Next slide. So let's start with some wins because I think this also goes to show the power of advocacy. And I know that as American Indian Alaska Natives, a lot of times we feel like our voices are not heard. Um, but I think that this goes to show that they are. So in FY 2026, of course, it's not full funding, but we had 8.05 billion for IHS funding. Advanced appropriations provided funding stability for IHS in 2027, which is 5.31 billion. And then our special diabetes program and why was reauthorized to 200 million and why that program is important because like we said at the beginning slides that really our voices in design and our ability to create what we know keeps our tribes and our healthy communities is really where we see great outcomes. And so the special diabetes program, the STPI, really has that ability to where we can decide it. We get stable funding and we can decide how that looks. We would like to advocate and we continue to advocate for stuff like behavioral health to look more like this model. Telehealth flexibilities extended for rural and health communities. We know that that's really important, but again, we have to make sure that our broadband is uh, out in our communities and that we can have good cell service for that. We were able to maintain some behavioral health and workforce programs, which is also always awesome. And then increase investment in rural health infrastructure and workforce. So those are some wins. I think those are exciting to talk about. And it's good to look like it's not always grim and our voices do matter. Next. So one day, a little story. One day we woke up and our $2 billion of our SAMHSA program funding in tribal communities were cut. Um, so this is a great story about advocation. I think everybody in the Indigenous community kind of came together and advocated, and really in record time, we were able to restore that funding. But again, right, when we don't have kind of in these crazy times, if you don't have really that feeling that your job is being stable, um, it shakes up the whole system. And this really affected our workforce salaries and services, put them all at risk, and it disrupted the system. I think that SAMHSA, in avocation, SAMHSA has done a good job of giving us a 5-year grant versus three, because what was happening in the 3-year grants is you would get money, it would take you about a year to hire somebody, you'd kind of get your program started, and then the next year you would lose it or reapply. So if you lost the funding, um, people again wouldn't have a stable job, and the program could just disappear and never really get started again. So that, I guess that was a win also, is that SAMHSA is providing 5-year grant funding, which is helpful. Next. So just kind of to brag about our policy team, because I think they're amazing. Also, I would love it if you all kind of help them, advocate for them. They do a great job, but they were able to send 45 rapid response letters to 11 federal agencies, really preventing that disruption to tribal healthcare services. A 900, and this, I think this was really scary too. So 950 IHS employees uh, were at risk to be caught up in that reduction in force, and we were able to keep those 950 IHS employees. Because can you imagine uh, already having that 35% uh, vacancy rate and then also losing 950 IHS? So that would be pretty devastating. The NIH director in tribal health research was reinstated, which was a good win. Um, and then we already talked about the reinstatement of SAMHSA's behavioral health and addiction grants. We were also had exempt for Medicaid and workforce requirements in the OBBA, which means, right, like if you are on Medicaid and having that workforce requirement, there's a lot of times in Indian country why you are unable to work. And so we were able to help with some of those exemptions. 938 listening sessions were held among our tribal communities, and that's really how we try to have a united voice. So if you want to participate, if you guys want to listen, please do that. Um, yep, next slide. So, like I said, our vacancy rate is still for IHS is still 35%. Over 1,000 staff have lost across the system since 2025. 43% of the facilities are vulnerable for losing services if one physician leaves, right? So it's at such a small workforce that if one physician leaves, those facilities could just lose all services, which is pretty scary. Um, so here's the statistic about kind of what I was talking about with my tribe, but hiring time of more than 250 days on average per hire, which is ridiculous, especially if we're trying to do those models that we were talking about, which means, hiring within community and growing your own. If we're trying to do that, they can't just wait to serve their community and wait for that job. And I think that's what we are expecting them to do, um, which is pretty disheartening. Also, I think that we talked about this within education, but it's still within the workforce, right? Having available and attractive housing, especially in those rural settings. Next slide. So IHS realignment. So it's proposed to restructuring of IHS headquarters and operations. It really wants to centralize the administration and operational functions. Um, and then a new thinking through having like a national oversight division under which is under consideration. So if we think about the bureaucracy and the difficulty of hiring and background, and then they put something more at a national oversight piece, what would that mean? That would mean like HR operations wouldn't be an area or local. They would be even higher up, and even more difficult to really help problem solve some of those issues. Um, so that is a concern. They did, IHS had held eight consultations. The public comment period is closed, so IHS will now continue to have an opportunity to make their decision and follow through on that. So we're following that closely. Next slide. So again, I think that reiterating what we're all saying, right? Work instability and burnout, delay in access to care, barriers to Native students entering healthcare, our gaps, our cultural gaps, and our cultural responsive care is bigger. And then workforce is the foundation of our healthcare. So if we cannot get our students in the workforce, we have a problem. And I think that's where we're seeing. Next. So just recapping, what works is really that expansion of CHAPS, those behavioral health aides, those community health workers, um, that peer support specialists, and really thinking through growing our own and having kind of a good partnership with tribal universities, community, um, and having kind of that reciprocal back and forth. Improving housing, we talked about that. Also, continuing to advocate for the 1115 demonstration waiver. That's where we can get our cultural healers paid, which I think, again, is when we are talking about workforce, we're talking about mentorship. We really want to expand that to lived experience, to culturally appropriate care. Um, and so that all ties into being able to also pay for our traditional healers. You guys already talked about this too, about advocating for the loan repayment, having the tax exempt go through. We are always advocating for that piece. And then also having or reimagining kind of loan repayment for higher graduate degrees. That's another thing that we really have to think through and advocate for, to make sure that our graduate degrees also have a good loan repayment. Next. So if you guys want to stay connected, and want to get kind of see what NIHB is doing, they have a weekly policy report, and it has links. It has what we're doing on the Hill. You can go to our webpage, and then follow the steps to sign up for our newsletter. We also are in the process of our new leadership, really thinking through a big strategic plan for NIHB. So we are working with a contractor called Shoreline, that we are getting into community, and we would love to hear how we at NIHB can be better, and do better, and kind of the good, the bad, and the ugly. So you also can find all of that on our webpage to provide comment there. And next slide. Also, our Tribal Health Conference will be August 16th through the 21st at the same place. I know it was hot. If you went last year, it was hot. So hopefully it won't be so hot this year. Hopefully we've figured that out. Um, but it was hot and tight, so just be prepared. And then the next 2 years we will be in a bigger space in Denver. So we would love to see you there. Proposals for workshops are out also. So if you feel that you want to submit a proposal, please get on our website and look for which proposals we might fit you appropriately. And I think that is all. I do want to leave you with one quote that I think is really important. Our strength has always been our people. When we invest in them, we are not just building workforce, we're carrying our community forward. And I think really understanding that when we're thinking through these solutions, we're thinking through policies, we're thinking through workforce pipelines. We have been here and we survived an attempt of genocide, right? And we are here because we know what makes us healthy. And so continuing to advocate for what we know, I think is one unified voice that we can really uh, try to advocate for. All right, any questions? No comments because you can't say that, my presentation at the beginning was really rough. But thanks for the grace.
That was fantastic.
Lacey,
I so full of so much content. Yeah.
Lacey, this is Mary. I have a question for you.
Okay.
Um, you mentioned we most of us are pretty aware of the IHS shortages like that you mentioned, but I appreciate a couple new statistics that I wasn't aware of, like the 43% going under if they lost even one provider. Do you have a sense of our tribal health facilities and shortages? I haven't found that.
So that's in our that 43 was not IHS, or the 40%, that's our tribal health organizations.
No, no,
Oh,
that 43% would go under if they are vulnerable if they lost one provider. Wasn't that IHS?
no, that's through our fix. So it could be IHS or it could be
Oh, really?
under
Wow.
your tribal health organizations.
Oh,
Yeah.
that's both. Okay.
Yeah, so the fix is the only survey that really talks about tribal health organizations around. Um, and the last edition was good, but we really need to our next edition is going to be amazing. So that we have better statistics. Obviously, the ins and outs of how it's almost sometimes comparing apples and oranges.
Yeah.
So we're really thinking through having better questions and making sure that we're doing some advocation to have even a more robust capacity scan. We are also trying to work and trying to get funding to work with PH Winds to do some workforce on tribal health departments. So hopefully you guys want to put that in the universe and smudge over it, that'd be great.
When was what's the date on that last fic that you did? And is it available on the
Uh,
website?
24, I think, or 25. We just re-upped it this year, which would be 25, 26. And it's a 3-year, so it's a 3-year project.
Okay, and the results on your website?
Yeah.
Okay, excellent. Thank you.
Oh, Tyrone, you're awesome. Tyrone has the fixed link in your comments.
That's
So,
great. Thank you. Any other comments from the crowd here? Oh, it looks like Kevin has one. Go ahead.
Yeah, I think anything I say probably has been said before. Uh, uh, One, in some ways, with what we're talking about with community and how we're raising families with children to develop into a workforce, that's wonderful. And my tribe is pretty big and pretty rural. I think some tribes are a little bit tighter, like, the Pueblos, they're really tight within their community, and maybe other examples across the country. But I think there's always, when I went to school, and maybe everybody here has experienced it, there's, if you go to school and you get educated and you try to go back, sometimes you feel like you're an outsider.
Right.
And so there's a disconnect in, okay, I always never really kind of understood the song of "Go, my son, get an education," blah, blah, blah. And it's sort of like, okay, I got the education. Am I welcome back?
Mm-hmm.
And I think it's a hard path, because other providers I talked to in AAIP, they said, when I went back and I served the community, and I made one, I didn't make a diagnosis, and the outcome wasn't as positive, and I was blamed, and they knew my family, and they knew my relatives, and word got round, and I feel bad. And so most docs kind of say, I'll take care of other communities, but for me to go back home, they know my family, they know my relatives, very difficult. Number two, it's sort of like, well, with that idea, is there a way that tribes can come up with the idea of how can we welcome back our professionals to the tribe? We don't have housing, we don't have the pay, but culturally, we are so rich. The exchange will be, we'll teach your family everything cultural, but please serve our community. And even like the idea of some countries where they have payback. If we give you funding, you give us 2 to 3 years back, knowing that we're not going to pay you. There may be no housing, but that's the trade-off. I think there would be some physicians like myself is like, sure, I'll be happy to go back, and serve. But those opportunities are missed because I think for whatever reason, it's not maybe acceptable. Who knows? That's another discussion.
Yeah. I agree.
Number
I've
two.
also, I've felt that
I
within
think
my own.
my son wrote a paper with Mr. Atone on land grab university. And that was the idea during Lincoln's time of the Murrow Act, where they had these properties and lands of various tribes that the state took over and said, okay, we're going to take these native lands, but the tribe agreed to say, okay, we'll give you these lands, but you're going to help educate and have these resources for our tribe. Well, that didn't really fall out. But once that article came out, I think it gave more ammunition to the students in Coeur d'Alene in Idaho to approach the board and say, you guys are a land grant university. Why are you charging our tribe tuition? They got that waived. I think that even happened in California with one of the tribes. So it's sort of like the idea of, we gave all of this country up in good exchange, and that value is still there. And you guys, for example, that's what happened with the Cobell suit. They were ripping off all the resources. Well, again, like there's probably a lot of other examples that still happen that way. But with these land grant universities, to me, it's sort of a resource, a banking of money and funding that you can exchange to have students go through and then go back and serve the community. It's a resource. Let's see.
Hey,
And
Kevin,
again, I think it's just that dialogue between, professionals and the tribe, because there's a disconnect. So hopefully you as an Indian board, you see that, and then you figure out, well, how do you try to match it? Because I think there's a crazy amount of opportunity. to have people come back and serve. Okay, I'm done.
We have time for one more question. I see that Susan has her hand up.
Yes, thank you. Mine isn't so much a question, but a comment. I advocate that new or baby docs, as they call them, new physicians do go back to their home reservation, but not until they've practiced elsewhere and gotten some seasoning behind them. Because a new physician going back to their home reservation, from what I've seen, will never be viewed as anything other than the kid they were when they left. So they need to get some seasoning under them and be able to stand strong, because otherwise they go home and they're viewed an apple. You're red on the outside, but you're white on the inside because you've learned too many non-native ways. So I encourage the ones I speak with to go out to other reservations and then come home after a few years.
I don't disagree with that sentiment, but the IHS doctors that come out, they're not experienced and they're practicing.
Okay, thank you so much, Lacey, for presenting. It was fabulous as usual. I'm looking forward, as I sent you a message, and the team already got back to me. We will be able to put iHeart on the end of NIHB again this year. So our conference will be at the end of that one, our live conference. Thanks for all the work that you're doing. I can't even imagine what it might feel like to be working in DC right now with all that stress you're under, but the advocacy that you pointed out from your organization has been phenomenal. So very much appreciated by many of the folks here. Miigwech, Gunash Chish.